Well, hello. Welcome everybody here in this room, and also to our audience online. We are going to start and quickly because, as you know, in the previous sessions have some delay, and we will try not to do this in this session. Well, I would like to introduce my co-chair is Thomas Clouseau, here from France, and I am Guillermo from Spain. And let's start with the first talk this afternoon. Is called BCL2 family inhibitors, and will be delivered by Courtney DiNardo. When you want.
Well, thank you so much for the invitation to be here. I'm similar to Eitan. I'm not sure how I got the invite to a primarily MDS meeting, being more of an AML physician, but I am so pleased to be here. These are my disclosures. And so, first of all, why BCL2 inhibitor therapy? Why venetoclax for patients with myeloid malignancies, both MDS and AML? And the whole rationale is that cancer cells in general, of course, want to evade cell death. And so cancer cells overexpress and upregulate anti-apoptotic proteins, which in hematologic malignancies, there is primarily BCL2. So you have more BCL2, which is binding these anti-apoptotic proteins, and then when you go with venetoclax or a small molecule BCL2 inhibitor, you release these BH3 proteins, which then bind to the pro-apoptotic expressor proteins, back, initiate apoptosis. And so this is the basic rationale of why venetoclax and BCL2 inhibition is so effective in patients with heme malignancies and myeloid malignancies. And while venetoclax actually only had modest responses as a single agent in the relapse setting of AML, in the frontline setting in combinations, and this is the VIALE-A data, in combination with azacitidine, we saw dramatic and now kind of a change in our standard of care, right? This dark blue line is the combination of azacitidine and venetoclax, which we're seeing doubling of a complete remission rate, a composite remission rate, 2/3 of patients now responding to therapy. It takes on average 1 cycle to respond, with a median survival of 15 months. And so that's the background that has led to the approval. But I want to spend, before I get into MDS, spend a few minutes on I think how we've learned in AML to hopefully optimize our venetoclax combination regimens, because I think this is really important, especially when we're thinking about how to use these combinations for patients with myelodysplastic syndromes. And so this, I think, is a really illustrative slide, which was presented by Keith Prats at ASH, which shows, again, that 2/3 of patients, right, respond to azacitidine and venetoclax, who have AML, older chemotherapy ineligible patients. Of those 2/3 of patients who respond, actually, more than 3/4 of them have received 6 or more cycles. So it's not like you get 1 or 2 cycles and you can't tolerate anymore, it's too toxic, they come off. Actually, 3/4 of patients continue on for over 6 cycles, but they're not receiving continuous venetoclax, right? So this slide kind of shows how patients, as we learned how to use azacitidine and venetoclax, people on average are getting about 3 weeks of venetoclax every 5 weeks of therapy. So 3 weeks on, 2 weeks off is how we've learned to best utilize this combination. We've also learned that G-CSF use is actually quite effective. So again, in the 2/3 of responding patients to Aza-Ven, about half of them receive G-CSF in the setting of a CR or a CRI. And data I'm not showing, but we showed that using G-CSF was associated with a shorter duration of neutropenia, fewer days of febrile neutropenia, and then in this Kaplan-Meier curve, the dark blue curve along the top, are patients who received G-CSF as opposed to those who didn't, who were randomized to azacitidine and venetoclax. And this slide is not showing that G-CSF, I think, improves survival, but it's showing that if you're using G-CSF therapy in patients who have neutropenia on Aza-Ven, you're able to stay on study, receive those therapies, the cycles at the beginning, staying on that tempo of therapy, and those patients are deriving benefit. The other thing we've learned to optimize is co-administration of CYP3A inhibitors. And this now is looking at VLA-C. So this was the combination of venetoclax with low-dose cytarabine. But this is a supplemental figure in this publication, which I think is really illustrative. And it shows that when you're using moderate or strong CYP3A inhibitors at a 50% or a more than 70%, 75% dose reduction, you're getting equivalent levels of venetoclax. And so I think one of the most important things about using venetoclax therapy in patients is being aware of these interactions. You know, we use ciprofloxacin very frequently. That's a moderate inhibitor, the azole antifungals, strong inhibitors, and so we need to be mindful to prevent significant myelosuppression. And so, you know, this is one of many updated kind of real-world experiences that I think is really important to highlight. And it gets to the question of, you know, is continuous 28 days of venetoclax the best way to give therapy? And we're still on AML here. So this is a group of 7 different centers within France that presented, Christophe Willikens presented at ASH in December, the 7-in-7 regimen, right? So in 82 patients who were particularly old or frail or ineligible for the VLA trial. So here you're seeing, you know, over half of these patients had secondary AML. Almost a third of these patients actually wouldn't have been eligible for the VLA criteria because they either had concomitant solid tumors or lymphomas or particularly poor performance status or renal failure. In this very high-risk population of 82 patients receiving just 7 days of venetoclax, you can see it takes a little bit longer to obtain a composite remission, but about 70% of patients are responding. Most of those responding patients are becoming MRD negative, and when you look at the survival of those patients that actually would have been eligible for the VLA based on those criteria, the median survival is 14 months here, and if you remember in the VLA was 14.7 months. So it seems actually, potentially, if this continues to be confirmed in other studies, that shorter durations of venetoclax may be equally effective. And I think that's, again, really important as we start talking about patients with myelodysplastic syndromes. Another slide or two on, still on AML, molecular prognostication I think is really relevant, right? And so this is looking at the VLA population based on different classifications. We started just with cytogenetics. Patients with core binding factor favorable risk were not eligible. And then we looked at how they would have been classified by ELN 2017 and ELN 2022. And you'll see more patients became adverse risk as the classifications evolved, right? Primarily because of MDS-related genetic gene signatures, which of course is more relevant in MDS patients as well. And the ELN classification actually really didn't do a good job of identifying who did and did not do well with aza-ven. What did do well was actually just a 4-gene classifier. Patients with P53 mutations in that dark blue along the bottom don't do particularly well, and you'll hear from David Sallman later on in this session about what we can potentially do for these patients. In the turquoise color, patients with signaling mutations, FLT3, KRAS, NRAS, do okay. And then everyone else, which was just over 50% of the VLA population, actually do pretty well with a median survival of over 2 years, 26 months. And so I think with all that as a background now, we can, pivot and talk a little bit about where we are with BCL2 inhibition and venetoclax in particular for patients with high-risk MDS. And this is the phase 1 trial that Jacqueline Garcia presented at ASH a year or so ago. This phase 1 trial had a bit of a storied past, right? It started with different continuous venetoclax doses, 400 and 800. And while there were no DLTs during the first cycle, which was, of course, the primary endpoint at that point, there were 2 patients who died in cycle 2 of these combination cohorts, infectious-related complications, which led to a modified dose escalation where 14 days of venetoclax were given at different doses. The recommended phase 2 dose was identified, 400 milligrams for 14 days, and then it moved into several different safety expansion cohorts to build on the experience in that particular recommended phase 2 dose. When you look at the 78 patients that were treated overall in the phase 1 study, you'll see that I've bolded the majority of patients have excess blasts and actually qualify for that new kind of ICC ELN greater than 10% MDS AML population, which is going to make things a little bit more complicated when we have 2 different venetoclax dosing regimens, 14 days for MDS and 28 days for AML. But as I think you're kind of getting the sense, I suspect shorter days of venetoclax even for AML may be the optimal way to do things. And then most patients high or very high by IPSSR. Just like we saw with AML, in MDS patients, it was even more dramatic, though, the degree of cytopenias, right? You're seeing along the top a lot of neutropenia, febrile neutropenia, thrombocytopenia. These are grade 3 and higher events that in MDS patients who are often treated in the outpatient setting, maybe not all on prophylactic antibiotics, not coming for as frequent lab checks. This was really quite dramatic, right? We do also see grade 1, grade 2 GI complications, nausea, constipation, diarrhea, which are usually quite manageable. But the median number of cycles received was 4. The 30-day early mortality was low, but again, you can see that second bullet along the top, almost 10% of patients had an AE leading to death, primarily infectious, which, as I'm suggesting, I think probably can be mitigated if we are potentially modifying and optimizing the ability, how we're using venetoclax combinations. The overall response rate overall in these 78 patients was 79%, with a true CR in green of just about 40%. When you look, of those patients at the recommended phase 2 dose, the 14 milligrams for 14 days, 84% of patients attaining an overall response rate, 35% a true CR, another 24% a marrow CR with hematologic improvement, and in that table, about 2/3 of patients becoming both red cell and platelet transfusion independent. So clearly, we're seeing significant responses with this combination. Survival in green is for all of those 78 patients, and blue is the recommended phase 2 dose, and we're seeing survivals with a median follow-up time of about 1.5 years. That in the recommended phase 2 dose hasn't quite reached the median mark. Again, encouraging that this is improving on azacitidine alone. And in patients who are responding, the CRs and the marrow CRs with hematologic improvement, of course, those patients doing particularly well. I want to focus on some data that Jacqueline presented at ASH looking at baseline mutations, and it's a little bit of a complicated bar graph because the height of the bar is the number of patients with the mutation, so I've just highlighted a couple things that I think are interesting. ASXL1 mutated patients seem to do quite well, and then 100% of patients responding with DDX41, we learned this morning, those patients tend to be very responsive to hypomethylating agents, splicing factor mutations, IDH mutations. The farthest bar on the left is P53, and unfortunately, while these patients often respond with marrow CRs, that unfortunately, again, does not correlate into an improved survival. And then focusing not so much on the molecular responses, but here on this swim plot, I think it's really kind of illustrative that the patients who are on the shortest amount of time, that kind of third of patients at the bottom who are not on for more than 6 months, most of them are actually going to transplant. So there was about 20% of patients that transitioned to transplant in this phase 1 study. And so otherwise, patients oftentimes are staying on for quite some time, over 1 year in many cases. And so that has led to the Verona study, which is ongoing, has completed enrollment, and we are, of course, anxiously waiting these results, which hopefully will be a new standard of care for MDS, just as it has been for AML, with the dual primary objectives of CR and overall survival. I'll focus in the last minutes just on a couple other real-world studies. This is from the MD Anderson looking at 10 days of decitabine with venetoclax, and this was looking at both many different cohorts, but in red at the right we had 20 patients with high-risk MDS or CMML in the salvage setting. So all of these patients had had prior therapies. 2/3 of them had had prior hypomethylating agents. So there's a question, can you give an HMA-ven regimen in patients failing hypomethylating agents, and can they respond? And we did see about 40% overall response rate, 20% CR, 20% marrow CR, and in the purple line now, a median survival of about 10 months. And so there are some patients that can be, that can see a response with the addition of venetoclax in the salvage setting. One slide that David Sallman let me borrow that came from Rami from an ASH presentation in 21, looking at a real-world Moffitt experience, which I, again, wanted to just highlight the fact that ASXL1 mutated patients do seem to do particularly well with this venetoclax combination and not respond as well to azacitidine alone. And so I think this is kind of a particular molecular subset, which we see a lot in MDS, which may be deriving particular benefit. One last study to highlight, one of many that are now looking at combinations with oral hypomethylating agents, of course, for improved convenience for our patients. This is one that our fellow Sangeeta Venugopal, who's now at Moffitt, presented at ASH, looking at ASTX-727, the oral decitabine with venetoclax. Only 9 patients presented at that time. We now have over 24, and we'll be, I'm sure, updating this at a meeting soon. Impressive responses, although primarily marrow CRs at this point, and so this is something that we're continuing to build upon. And in the last second, I guess I'm ending on a bit of a negative note, but I want to make it clear that I think venetoclax and azacitidine for high-risk MDS has a lot of promise, but I think it's probably not going to be the cure-all for all of our patients. And we already know there are many different resistance factors. We've talked about monocytic expression, signaling mutations, upregulation of MCL1, BCL-XL, as well as P53 mutations. And so there's a lot of different ways that resistance can happen, and we need to figure out how to work on this and make things even more effective for our patients in the future. And so with that, I will conclude with the statement that I do feel that BCL2 inhibition is a key strategy for myeloid malignancies. It's already there in AML and hopefully soon for MDS. But we need to do an effective job of managing myelosuppression, cytopenia-related adverse events, especially in our MDS patients where that is even more of a pronounced problem. And with that, I will close, and I want to thank you all for your attention.
Thank you so much. So we will have a session of Q&A at the end of the session. So the next presentation is Emerging Therapies, presented by Guillermo Garcia-Manero.
Thank you, Thomas and Guillermo, for the opportunity. So I'm going to focus on oral hypomethylating agents. When I look at the program, I think that we had BCL2 covered, antibodies, etc. So I thought that this will be an appropriate use of the next 15 minutes. So these are my disclosures. So the question is why we need such approach. So I don't need to tell the audience, that many of whom actually helped develop and approve these drugs, that both AZA and decitabine are the standard of care for myelodysplastic syndromes and older AML, but they require 3 to 7 days of either intravenous or subcutaneous administration. One key factor, and this was published by Dr. Cabrero, who is now in Salamanca when he was in Houston, is actually interruption of these compounds in patients that are responding to therapy is associated with acquisition of resistance and basically then a dismal prognosis. So we also thought that having an oral compound could allow for multiple oral combinations, maybe facilitate the use of these compounds post stem cell transplantation, and therefore we thought that this would be kind of important to study. So there are 2 approaches to development of these compounds. One is to combine the hypomethylating agent with a drug that inhibits the enzyme known as cytidine deaminase. There are apparently at least 2 ways to do this. One is using another drug called cedazuridine. The other is with a compound known as tetrahydrouridine. I don't have experience with this last compound. The other approach is to do this kind of just with the hypomethylating agent itself and see how much you absorb of the drug. That's the approach actually that CC486 uses. As you will see in a second, there are very significant differences in terms of pharmacological profile of these compounds. So let's start actually with the very first study. And this is actually for kind of historical context. So this is the original phase 1 trial of what we used to call oral azacitidine, now CC486. And here, basically, at the beginning, we were thinking that maybe the PK profiles were not going to be that dissimilar. So if you can see in the slide, on cycle 1, we gave this drug subcutaneously. We got all the PK data. And then on cycle 2, we gave this drug orally, and we got all this PK data. And the idea here was to, like, intra-patiently compare the pharmacological profile of these drugs. And the results were kind of disappointing, actually, although not so. So just wait for the next slide. But what you see here is actually that the area under the curve in white, that is the oral azacitidine curve, was actually significantly lower than what you see for the parenteral version of this compound. So actually, when we first saw this data, before actually got the clinical activity of this trial, we were thinking maybe actually this is not really a drug because the exposure is so low. It's around 13%, as you see there. But then we got the clinical responses from this trial, and this all published data several years ago. And if you see there, if you look, for instance, at patients during cycle 7, around 45% of these patients had a response to this therapy. So I actually immediately thought, well, wait a minute, maybe even these lower doses of these HMAs are high. Maybe we can even go lower. And that's actually why for many years we've been using these hypomethylating agents for lower risk disease, but that's maybe the topic for another session if I invite it. Now, what is also interesting is that despite the fact that the exposure was very minimal, actually this had an effect on global methylation profiles. So here we use an old chip array that we used to use for global methylation assays. And if you can see, let me see if I can point here, there is basically a significant decline that is always reversible with this kind of therapy, similar to what we had seen with IV decitabine or azacitidine. So with all that, there were 2 studies designed. I maybe picked the wrong one. Well, I don't know, I'm not sure. There was one for AML, one for MDS. The AML, you know, was positive for post-constellation therapy. This is the 003 trial. It's actually, don't have time to go, nor is the point of the talk today, but this was kind of like a complicated result because the drug actually resulted in hematological improvement. But the study was powered for survival. And the population and the toxicity of this drug at 21-day schedule was too much. So the study is actually negative. Now, we're kind of revisiting this trial. There's another version of the study going internationally, starting to accrue. So maybe this time we'll have an approach with the oral azacitidine. But that's where we are with this particular compound right now. So then we, instead of like saying, well, this is not going to work out, we thought, well, how can we kind of like keep going with this concept? And we had the opportunity to work with people at Aztecs and some investigators in North America and trying to explore this idea of incorporating the cytidine deaminase into a potential true oral hypomethylating agent in the sense of similar absorption. So this is the oral decitabine cedazuridine. As I indicated earlier, this cedazuridine inhibits this catalytic activity that you see in the middle of the graph. Basically, that allows, someone said earlier this morning, the inhibitor of the inhibitor. So basically, by inhibiting this enzyme, you have unconverted decitabine. That is the active compound of the therapy. So that was exciting. You know, they had this drug known as E727, that is the cytidine deaminase inhibitor. So the original phases of this trial, actually, we were playing with the oral decitabine formulation and the E727 as 2 different drugs, trying to figure out what would be the ratio of those 2 drugs together, although the drug now is basically both encapsulated in the same tablet. And this was actually, as an investigator, a lot of fun because we were doing cohorts looking actually at the PK/PD profile and trying to match this to the expected profile with the IV drug. And then in this table, basically, what you see is the different ratios that we use. For instance, if you look at cohort 1, it says DAC 20, E727 40. And then you see that that gave basically 35% of the EUC. So that's too low compared to what we wanted to do if we wanted to achieve 100% exposure compared to IV decitabine. And then if you go to cohort number 4, we overshoot it, right? It's 144. So we're trying to figure out what will be the proper ratio of the cytidine deaminase inhibitor with the decitabine that will take us close to 100% similar or identical to that of IV decitabine. So after a number of studies, phase 1, phase 2, a lot of this work done with Dr. Savona that is here, we designed this phase 3 trial that is known as the Ascertain trial. And I think this is a very interesting concept in terms of drug development. So this is the rationale. I already went through this, so skip. This is just showing the PK curves of the exposures of these different formulations, and this is the schema of the study. So just to clarify what this phase 3 study is, because we've been criticized that this is not really a phase 3 trial. This is actually a phase 3 randomized registration trial. So what we did here was to randomize between two different sequences that we call A and B. And what we see is that the first two cycles are different depending on whether you're on the top one, A or B. So in the first one, for instance, in cycle 1, you start with the oral ASTX727 that has this ratio of 35 to 100 that we think is the optimal dose. And then in the second, you had IB. And then you go and compare for each patient the PK profile. In sequence B is the reverse. You start with the IB, and then you continue with the oral. After that, everybody continued with the oral approach. And then this is, in my opinion, such a beautiful, clean, elegant primary endpoint. That is, what is basically the ratio or the correlation between the PKs between both. And as you can see, there is 99%. That is almost kind of, when I see this in a paper as a reviewer, I'm always like, this data is actually maybe too perfect. But that's, I guess, what it is. So really identical PK profile between the IB and the oral. Then we looked using an assay known as the line methylation assay. This is a way to look at global methylation, the profile of induction of hypomethylation between the oral and the IB, and you see they're basically identical, 13 versus 14%. That is very similar to what we have seen with IB decitabine in many prior other studies. Now, when we first presented this data at the ASH meeting, I think it was 2019, we didn't have clinical data in terms of responses, et cetera. So there was a question of what does this really mean? It's nice PK/PD profile. The following year, Mike Savona presented the clinical data. And what you see here is that the CR rate with this drug was 22%, so it looks kind of nice. And then the survival actually looks also kind of nice. Now, this is not a study that is powered to look for survival. And there was a question of whether there were a lot of kind of low-risk patients, because this study basically was open to anybody that had the label for decitabine. The United States actually includes patients with lower-risk disease. So it's possible that this could have been, quote-unquote, contaminated by patients with very good prognosis. But I'm going to show you actually that the reverse happened. So at this past ASH, Dr. Savona had a really nice presentation on the kind of look back at the genomic architecture of these patients treated on the ASCERTAIN trial. And, we focused on those patients with P53 mutated disease. As you've heard through the meeting today, this is like the gene you don't really want to have, right? So when we profiled these patients on the ASCERTAIN trial, maybe that's too small, but the second column actually are those with P53 mutated disease. And you see actually that in this trial, this was the second most frequently mutated gene in the whole cohort. So this doesn't look like a good prognosis group of patients. And then we actually looked at, what that, presence of that mutation impact in terms of outcomes. And I think this data is very interesting. Maybe after we hear Dr. Sallman, we can discuss why this will be the fact. Of course, it's just one study. It's not powered to do that, but I think there is something here. So on the left, you see the leukemia-free survival, and it's 22 months for those patients that are mutated for the P53. Of course, it's worse than the wild type. If you look at the right, that's the overall survival. The median survival for these patients is around 25 months. If we look, for instance, at data presented by David Sallman with APR, it's actually a bit less than a year or so. All our prior data at MD Anderson was a survival in this group of patients around 11 months. So these numbers appear to be a little bit higher than what you will expect in this group of patients. The question is really why. So that's really exciting. And then, of course, you could say, well, maybe they were all monoallelic. That's actually kind of impossible. But we looked at this, mono versus biallelic. And actually, in those patients that were biallelic, the survival was around 13 months. That is also kind of better than what you will expect in this population. So that's like an intriguing observation. And the question is, why is this the case? And I think we need to think a little bit more about why this happens. Now, this is one example. Dr. DiNardo, Courtney just talked briefly about this the total therapy with the oral decitabine with venetoclax. This is going to be updated as an oral presentation at the EHA meeting in a few weeks. So this is preliminary data, okay? So you cannot copy whatever, and I don't want it to be embargoed. But actually now we have like around, I think it says 40 patients on this trial. And the overall response rate is around 94%, including a complete remission rate of 39%. There's a lot of controversy now in terms of what these MCRs mean. It's like 54%. But I can tell you that we're starting to see complete cytogenetic responses and molecular responses, MRD negativity on this study. So this will be presented in its totality as an oral abstract at EHA. But actually, this seems to be a really powerful combination, and maybe is as powerful or more than combining this with azacitidine and venetoclax, maybe better than single-agent HMA. I'm not sure. This needs to be tested in other clinical trials. So to finish, I think first I'm going to give you a little bit of where we are with these drugs. So we have the 727. This is the oral decitabine. This is approved in North America, I think in some other countries, for the same indication of decitabine. Then we have CC-486. This is the oral azacitidine that is approved for AML, that is being re-studied in myelodysplastic syndrome low risk. I actually think that we should really think about how to put this drug also in high-risk disease. I think Dr. Fenot and the French group has some combinations with venetoclax, so this is something that I would like also to see. And then you should be aware that there is another compound known as 030 that is actually azacitidine with azacitidine, the amylase inhibitor, that is actually undergoing, actually is in a very advanced stage of phase 1 trials, trying to follow the same path that we had with the oral decitabine cedazuridine. If this happens, then we'll have a kind of oral azacitidine with the same PK/PD profile than a regular azacitidine. Now, as I mentioned in the first slide, we are interested not just because we like oral drugs and we feel bad about our patients spending so many days in the clinic, because we think actually furthermore that there's a lot of research opportunities. So we're studying this in low-risk disease, and more importantly, there are a lot of different combinations. So we have an alliance at MD Anderson, and active studies that are already being presented at meetings are combinations, doublets and triplets with IDH1, IDH2 inhibitors, with venetoclax for sure. This is mainly for AML, FLT3 mutated disease. There's a study now starting that already accrued around 5 patients, combining one of the menin inhibitors with these compounds with a really high rate of response. And interestingly, actually, the pediatricians are starting to put this in their practice. So we're coming with either a different formulation or different schedule, trying to treat kids with MDS, AML, with this kind of hypomethylating agents. There are studies looking at these drugs post-transplant. I think an oral approach will facilitate this idea of total therapy, and we're basically kind of intrigued about this 030. And then with that, I would like to conclude. So in summary, these drugs have different PK/PD profile depending on their context, depending on whether they are combined with a cytidine inhibitor or not. Then CC-486 has a lower exposure, but you give it for more days, so maybe that will equilibrate that issue. I already talked about the indication for 727, 486, 030, the excitement about these combinations that are quite advanced. Actually, I think we're going to see very clearly how we give these drugs before transplant and then after transplant. And I think this issue of the activity of this particular compound in P53 mutated disease is quite intriguing, and we really need to follow on this lead. And with that, I would really like to thank you for this opportunity.
Thank you, Guillermo, for this excellent presentation and for sticking to time. Our next speaker is David Sallman, and he will talk about therapy of P53 mutated MDS patients, this very poor prognosis population.
Thank you to the chairs for the introduction, and it's really an honor to be here. This is really my favorite meeting happening on a biennial basis. So again, I think I'm tasked with talking about, the molecular subgroup of patients that really most urgently requires a change in standard of care. These are my disclosures. So I'm really looking forward to the presentation tomorrow, really this sort of debate around ICC, WHO. Of course, a lot of the discussion is particularly around this MDS AML subset of 10 to 19% blast. And although I don't think this is created equal across all molecular subsets, I would say the most data is really profoundly supportive of this in P53, although I'd support maybe more of an MDS backbone in that setting. So what data support that? So multiple groups have shown this. To me, this is the more seminal publication from the Hovan group. And if you look on the right with AML in red and MDS and excess blast in orange, this is actually greater than 5% blast, and I actually argue that we should think about that definition in this patient groups, but you can see that the curves are completely superimposable, and again, shown by multiple others. So I think we all are in agreement that these patients need to get on trial, and thus trying to urgently get there, potentially not waiting for next-gen sequencing, or potentially having the idea, is my patient P53 mutant or not, is really a key consideration. It's a really nice work by Austin, the King's College group originally. So if you look at aberrations of chromosome 5, particularly in the setting of aberrations of 7 and 17, you could predict with up to 100% certainty that having the presence of a P53 mutation, you could do this with an MDS FISH panel. Actually, some centers in US are doing same-day MDS FISH panels for this reason. You can similarly just do a basic p53 immunohistochemistry. This stains the accumulation of sort of misfolded protein in mutant patients. It's strikingly concordant with the presence of p53 mutation. And what's nice is you can follow patients with this. So this is just a representative example of a patient in complete remission where you really get complete elimination. And this actually ties nicely with really p53 VAF clearance at the same time. And then recently by the MD Anderson group, again, really identical data validating this in AML, which again is not necessarily surprising given the overlap, from a biological perspective. Lastly, this is actually first shown by Professor Malcavati with in adverse risk patients with ring sideroblasts. You have presence of p53 mutation. So we looked at this both in our cohort as well as a validation cohort. And in patients with more than 5% ring sideroblasts with excess blast of 5% or greater, over 70% of these patients are p53 mutant. If you then combine that with aberrations of chromosome 5, you can see over 90%. And then in contrast, patients with increased ring sideroblast, excess blast, but a normal karyotype, almost none of those patients are. Again, something you can turn around quite rapidly. Again, we all know that the p53 mutation predicts for poor outcomes, but I think this was sort of one of the original studies looking at this. If we parse this by the variant allele frequency, in this case greater than 40%, they're less than 20%, really the only long-term survivors were seen in patients with that lower VAF. Actually, this VAF of 20 to 23% has now been shown by multiple groups to potentially best stratify these patients as well. And then very elegant and really seminal work by the IWG Molecular Committee, published and presented multiple times by Elsa Bernard at this meeting. Clearly, the multi-hit patients do worse than that. Although, again, if you look at the supplement patients with a variant allele frequency greater than 23%, the vast majority of those patients do have poor outcomes. So there's been a lot of discussions around allelic status. Actually, if you look in our high-risk trials, often 85 to 90% of the patients will sort of fall into that. And actually, in patients with excess blast, again, this is data from the Hovan group and the MDS subset, you could see there was no impact on predicting the allelic status. Similarly, in data from our center presented at ASH, again, in complex karyotype patients, albeit many of these patients, are double hit, there was no difference in in a single hit versus double hit with complex karyotype. It may be best for stratifying patients with either, low blast or non-complex karyotype, where you can really pick out some of those patients that have an indolent prognosis. And I think that's key when we're looking at patients and outcomes. So what is going on in these patients? Not enough time to go into this in detail, but p53 mutant patients have a very strikingly different immune microenvironment, and it's very adverse. So if you look at PD-L1 overexpression on, for example, LSCs on mutant versus wild type, you get this PD-L1 upregulation. And there are a number of immune adverse features, lack of activation receptors on killer populations. And we see increased of immunosuppressive populations, MDSCs, and particularly this ICOS high PD-1 negative Treg population that would correlate with outcomes. Actually, similar data shown by the MD Anderson group as well. And mechanistically, as far as PD-L1 upregulation, again, two known regulators of MYC and miR34, you can see as MYC is increased, the percentage of PD-L1 positivity on the LSCs in mutant patients goes up. And similarly, the only microRNA to be significantly downregulated was miR34A. A nice collaboration, with Ben Ebert, who had recently published his data in Science, and it was nice to share sort of these missense knock-in or knockout models. You could see versus isogenic, wild-type cells, you have this MYC overexpression, complete miR34A ablation, and ultimately increased PD-L1 upon interferon gamma stimulation. And I think these really speak to the ultimate impact of this. So this is an AML study looking at single-cell cytokine analysis and the functionality of these T cells. Not surprisingly, in relapsed patients, again, they have profound T cell dysfunction. But what is striking, if you look at newly diagnosed AML patients, again, before therapy, they are basically equally as profoundly suppressed as relapsed refractory patients. Really a major issue in this patient group. So what is our backbone of therapy? I think across MDS and AML, although I would argue that there is no good standard of care, I do think HMA represents that backbone. Response rates are overall relatively equivalent between mutant and wild type, but many groups have shown that the survival is significantly impaired, really 6 to 12 months being across MDS and AML patients. And although there were suggestions of 10-day decitabine improving outcomes in randomized trials, including 10-day decitabine and venetoclax trials, at least in AML patients, the median survival has been around 6 months. So what about, again, I think we heard really nice data by Courtney DiNardo just a little bit. And again, I think to focus on the true complete remissions, this is data published by Pollier and colleagues. If you look at the true CR rate in poor risk cytogenetic patients is only 20%. I argue not different than single agent azacitidine. And again, this was also kind of shown in a similar format by Courtney. Again, I think if we look at true CR, which is the most relevant response in this patient group, it's only 16%, again, similar to what it is in p53 mutant patients. I'd really like to see the overall survival data in this subset from the phase 1 publication. And I think this, lastly, thinking about these patients, the clinical trajectory of these patients is tightly correlated with the variant allele frequency. So you can follow this sequentially. Some of those indolent patients that have good outcomes are patients that will sequentially have a VAF of less than 20%. But if you look on the right in patients on therapy, patients that can clear that p53, this is just to less than 5%, not MRD, have improved outcomes. And maybe where this is best utilized in clinical practice today, and I think nicely shown by Seshi Ogawa's group in an abstract yesterday, patients at p53 clearance are that group of patients that have improved outcomes to transplant. You could see a hazard ratio of 0.28, whereas patients that did not clear actually had no benefit for transplant in this setting. And thus, potentially for patients that are sort of borderline for whether or not they should go forward with transplant, this should be a key consideration. So kind of switching to novel therapy, so eprinetapopt or APR-246, which is really one of the first agents to look at specifically in this p53 mutant patient population, can ultimately lead to the activation of p53. But there is sort of a plethora of MOA, including ferroptosis induction, that may be critical at the same time. So just to briefly, kind of just one subset, these are from the JCO publications on the topic. I think one thing to mention is, again, true complete remission is highly concordant with VAF clearance. And I think in this patient group, we really need to think about international collaborations. So this was really done with Thomas Clouzot here from the very beginning. And in a parallel GFM publication, really overall quite identical response rates, true CR rate in the MDS patient population of 47%. We put these data together, and just to focus on this transplant question, again, if you look at landmark analysis, actually there was no survival improvement in patients that went to transplant. But if you parse this by the response status, so if you focus on the green curve, patients that went to transplant with CR, and particularly with p53 clearance to less than 5%, had a median survival that was not reached versus a median survival of 9 months in patients going to transplant without molecular clearance. So these led to the phase 3 trial. I think all, very disappointed. We really still have one sentence as far as the CR endpoint being increased, but not statistically significant. We really need to have these data. I mean, this is enrolled by multiple people in this room. I'm pushing the company on a monthly basis. Just how do these patients do in a prospective randomized trial? I think those are key options from that perspective. Just what are the other data? So I did just focus on the post-transplant question in this setting. This was done by Dr. Mishra at our institution with a reduced schedule of eprinetapopt and azacitidine, a little bit of a cherry-picked population in the setting that they had engrafted with no GVHD and were in cytogenetic remission at the time of transplant. But if you look at the relapse-free and overall survival, actually very favorable. You could argue sort of double from historical cohorts. But it may be sort of some of this early initiation of hypomethylating agent therapy. This is actually something I do off study in all of my p53 mutant patients, and hopefully we'll be putting some data together on this at ASH as well. So what else is there? So Dr. Padron at our institution actually did a genome-wide CRISPR screen. This was presented at an oral at ASH, looking at resistance to eprinetapopt and azacitidine. And XPO1 was actually the top hit. He's nicely shown this in vitro and vivo models and actually working on the PDX data as we speak. And this really strongly supports an eprinetapopt eltanexor combination, and we hope this trial can happen sometime this year. So moving on to magrolimab, and I think we'll hear some additional from Dr. Brunner in a moment, but I always sort of like to show this video of cancer cells in green and macrophages in orange, where you get no phagocytosis in the absence of antibody, whereas in the addition of magrolimab or other CD47 SIRP-alpha inhibitors, you get this rapid induction. What is key is that the pro-eat-me signal is really required for this to occur. This is largely only occurring on cancer cells and really allows for selective elimination of cancer and minimal on-target off-tumor tox. So the one exception, so this is just the design of the trial. Again, these data have just recently been published, at least from the MDS cohorts in JCO this past month, again, with a standard azacitidine schedule. And I'll focus sort of on the p53 data in a moment. So again, other than infusion-related reactions, actually grade 3 occur in about 5% of patients, so quite rare. This sort of on-target anemia is definitely a significant safety issue, but it's really an issue not only just first cycle, but really first week. So predominantly the day 1 of therapy, that's when you can get these large drops of hemoglobin, 3, even 4 grams per deciliter. So we mitigate this with this priming dose. We keep all patients above 9 grams per deciliter at baseline, and really through close following, across that first week, it's not an issue over time. You could see over time associated with response that the hemoglobin goes up. and actually really nicely shown at ASCO this past year by the Stanford group, is patients on chronic magrolimab, actually on the RBCs, they prune their CD47, which is part of the reason this is not an issue for patients on ongoing therapy. Again, the overall response rate was around 75%. The true complete remission rate was between 30 and 40%, but just kind of focus on the survival. Again, this is across all patients, not just P53 mutant. But if we parse this by, again, wild type versus mutant status, the median overall survival in wild type was not reached, with over 60% of patients still alive at the data cutoff. And then in a cohort of 25 patients with P53 mutant, you can see a median overall survival of 16 months. Again, this is in a patient group that was almost all double hit, a variant allele frequency, of around 40%. Again, a very adverse risk population, and I would argue quite favorable versus our historical cohorts between 6 and 12 months. Again, because we're thinking about MDS and AML together, these are our AML data, presented by Naval Daver at this past EHA. AML patients still somewhat have a worse prognosis, but in this group, we have a median overall survival of around 11 months. And again, still going back to that, part of transplant, and I think that's a really key consideration in these trials. Again, 9 patients, small cohort, but a 1-year overall survival of 83% in the patients ultimately bridged to transplant. So what else is ongoing in the setting of P53? So this is an IIT at the MD Anderson group, which looked at the triplet of azacitidine, venetoclax, and magrolimab with quite impressive CR rates. It was really a highly P53 trial. That was the vast majority of these patients and was recently updated at this past ASH. To me, what was most intriguing is they did a sort of retrospective comparison versus HMA venetoclax patients treated at their institution. And again, we now have sort of a doubling survival of the triplet versus the doublet. Although, again, if you remind yourself from the last slide, the median overall survival of here was 10.4 months. It's essentially identical for what we've seen in the doublet. And thus, I'm really, I'm not sure that the addition of venetoclax, even in the setting of magrolimab therapy, is adding much in patients that have P53 mutation. But fortunately, we are going to be able to answer this question. These are the 2 ongoing randomized phase 3 trials in AML. Again, the ENHANCE-2 trial is an open-label study, and I think Keeley recognizes that independent of age, these group of patients do not have a standard of care, and thus it's an open-label study of either azacitidine and venetoclax in patients that are called non-intensive, and this is per investigator, versus induction chemotherapy in patients that are considered fit for induction chemotherapy, although the trial's primary endpoint is powered for the non-intensive arm. There is similarly a triplet trial that, again, is triplet versus doublet. This is exactly the Viale population. This is a double-blind placebo-controlled trial, and I expect that probably at least 25 to 30% of this cohort will be P53 mutants, so some cross-trial comparisons. Lastly, again, this is a multi-cooperative group trial in the United States called MyeloMatch, which is essentially separated by patients either over the age of 60 or less than the age of 60, and I think maybe builds upon a little bit on Guillermo's presentation in the last talk. This is with ASTX727 or oral decitabine, and it's going to look at the triplet versus the doublet. Again, key in both the P53 studies is that the primary endpoint of these trials are overall survival, which I think is sort of absolutely required when we're thinking about treating this patient population. This trial should be initiated actually quite imminently. The protocol's been done. And again, we may be able to then compare sort of ENHANCE-2 versus this trial, thinking more about that triplet versus doublet question. And with that, thank you for listening and looking forward to the discussion section. Thank you.
So thank you. So the next presentation will be about antibody-based therapy of myelodysplastic syndrome, presented by Andrew Brunner. Thank you.
Merci. Thank you very much for having me. Let me see if it's a real honor to be here and to talk to you about antibody therapies in MDS. And hopefully this is a nice foil to some of the discussions that we've had so far. And here are my disclosures. I will be talking about off-label drug use, sabatolimab and magrolimab. And so when we talk about the use of antibody therapies in MDS, there's a lot of ways that we can employ antibodies therapeutically, and they all have different strengths and weaknesses. We can target cell surface antigens on the leukemic blasts or MDS progenitors themselves, CD33, CD70, these have been explored. We could go a step further and use an antibody to deliver a toxin directly. So gemtuzumab ozogamicin may be the best known. There are many other novel ADCs that have been explored trying to utilize some sort of targeted chemotherapy delivery. We can use some advantages of antibody behavior to prolong durations. Antibodies have a nice way of lasting in our serum, and so you can decrease the intervals of visits for patients if you utilize parts of an antibody, which is important in MDS to improve their quality of life. We can use bispecifics. CARs and bispecifics try to engage with the immune system directly to bring them into proximity of a cell. And then what I'll be really focusing on here is that we can try to modulate the immune system, target various mediators of the immune response toward a malignant population. PD-1, CTLA-4 have been explored, but then really looking at TIM-3 and CD47 and where they are. And I'm reminded at this meeting, and anytime I get the chance to talk with others about MDS, that we don't live in a vacuum. You have a clonal myeloid population in the marrow, but you also have a whole microenvironment of other cells that are interacting with the marrow. And when we employ an antibody, we really can disrupt those kind of interactions. And thinking about what the goal of that is and how to anticipate the effect of that interruption really should go into how we design our trials and what we expect to see from them. And so today I'll be focusing really on TIM-3 and CD47 antibodies in MDS. TIM-3 antibodies have targeted the interaction between TIM-3 and its ligands, phosphatidylserine and galectin-9. Sabatolimab is a TIM-3 antibody that's in late phase development, and I'll go over the phase 2 study and phase 1 study of that. And then we just heard about magrolimab, which is a late phase development agent targeting the CD47 SIRP alpha interaction. And I hope that I can maybe talk about what do we learn so far from our antibody-based therapies in MDS. What should we expect from a therapy that targets the immune system? And how can we design our studies, phase 1, phase 2, phase 3, appropriately so that we capture benefit? And I think that one of the lessons learned came from Amr Zaidan earlier. So this is atezolizumab. It is a PD-L1 inhibitor. It was combined with azacitidine. Here's a randomized trial in MDS of azacitidine plus atezolizumab versus azacitidine alone. I think a challenge in any early phase study is knowing what toxicity is expected. And if you have a febrile neutropenia rate, is that beyond what you'd expect? The nice thing of having an early phase 2 study that's randomized, adding atezolizumab was a more toxic agent than azacitidine alone, so you can really discern that. The other thing you can get a sense of, is really hard in a single-arm study, is the response rate actually different from what I might expect? And here you can see that across mutation profiles, there really was no difference in response. And so how do we think about TIM-3? And so moving on from our classic PD-1, CTLA-4 axis of immune therapies, if we employ a TIM-3 inhibitor, what would we expect from it, and why would it be beneficial potentially in myeloid neoplasia? Well, one of the preclinical studies or pre-treatment studies suggested that if you take patients who have had an allogeneic transplant and then monitor their T cell populations, at the time when they're relapsing post-transplant, there's an increase in a TIM-3 positive, PD-1 positive T cell population, kind of a T cell exhaustion phenotype. And so maybe if we interfere with TIM-3, we would potentiate any possible immune versus MDS response, or at least try to prevent or delay the loss of an immune response. Does that mean that you have to have a response first, or an immune response to be able to potentiate that? Second, TIM-3 expression seems to increase as the blast population increases. So this is an example from CML. You can see it from chronic phase to accelerated phase to blast phase. The TIM-3 expressed cells increase. And so does TIM-3 inhibition have a potential impact on blastic progression, maybe in contrast to hematologic progression? And so would you be looking specifically for that? And then last, here's a study that looked at serial transplant in a mouse model of AML, but if they administered a TIM-3 antibody, they were unable to serially transplant that model. And so would TIM-3 inhibition, or any immune therapy in particular, have an impact around transplant and affect the graft versus leukemia versus graft versus host effect? And so we participated in a phase 1 study combining sabatolimab with HMA. Here's the overall response rate. I think a common theme is that CR is a consistent, it's a strict criteria, but it is the one that we can compare across studies. There's a lot of heterogeneity with responses outside of CR. And some of those are good and some of those are bad, and I hope that we are moving toward better response criteria. But focus on CR across these next studies, because that's probably the only metric that we can reliably use to compare study to study. Of patients who responded, the duration of those responses was reasonable. I will note patients were censored at the time of transplant. So you saw Courtney DiNardo presented where a number of venetoclax patients came off the study. Those early patients going to transplant, we're going to censor that data, and it's really important to capture post-transplant outcomes. In fact, we went and we retrospectively assessed post-transplant outcomes for the patients that did go on to transplant. And in part, we wanted to see was GVHD a problem, but we also see that they did reasonably well. These are AML, CMML, and MDS patients going to transplant with a 2-year follow-up. So that led to a phase 2 randomized double-blind placebo-controlled study, Stimulus MDS-1. And so shown here are the 2 arms. They're a pretty typical high-risk MDS population, older individuals. I will just pull out, and I think this has also been mentioned in other talks, over a third of these patients had a p53 mutation. And when we enroll a study, and if we have a large proportion of patients that are a single mutation, we have to think about how that's going to impact our expected outcomes, and also just how did we power our study. If we have a group that's going to do much differently than our expected endpoint, will that change our power? And so the primary endpoints for this, again, a phase 2 study, were remission rate and progression-free survival. And so the CR rate, which you might have expected from the phase 1 study, was unchanged between sabatolimab and HMA versus placebo plus HMA. And the progression-free survival, there was no marked difference between the groups. The p-value was 0.1. This is a phase 2 study. You wouldn't expect it to be powered to find anything but a very large difference. A challenge we don't know, and which is yet to be answered, is whether PFS is a surrogate endpoint for overall survival. Moreover, you see that if there is any difference between those survival curves, the progression curves, that really didn't happen until there were only about 40% of patients left. So if you're using an immune therapy that you think might potentiate a response in responders, and you only have a 20% response rate, really you might need to wait for that tail before you know whether that is going to have an impact. Who might benefit most from sabatolimab if there is a benefit? And this is the kind of thing that might then go into inform a phase 3 trial enrollment schema. But you can cut it a number of different ways. It tends to be lower risk patients by IPSSR or IPSSM or low blast. What does this mean? Maybe patients who can stay on therapy the longest to potentially see if there is an immune effect, would that have anything? If you look at the TP53 mutant population, no difference in overall survival. And so again, when you've enrolled over a third of your patients on the trial have a p53 mutation, how does that impact the expected power for the rest of the patients? You can see that in the wild type group, actually their longer follow-up is needed because really they haven't reached enough events. And so what have we learned from sabatolimab, and how can that inform our understanding of both the larger phase 3 study and as well as magrolimab and other phase 3 studies in MDS? Patient composition should set our expectations, especially with mutation enrichment of certain groups. It's very hard to compare responses across studies to predict whether something's going to have a higher response rate. We're kind of stuck with the old CR, reliable, but only a few patients get it. The duration of response is going to depend on a number of responders. And so if you have a low response rate, that's going to limit that. And then we also have to consider trials, I think, with different phases of disease. Are we trying to improve the response rate? Are we trying to maintain a response? And I think throughout MDS trials, the importance of a placebo arm early has such a big role, especially in mutational subsets. So CD47, we heard a little bit about the rationale for that. We saw a nice video. I only have a graphic here, unfortunately. But magrolimab interrupts this don't eat me signal from CD47 interacting with SIRP-alpha on the tumor. Calreticulin is one of an eat me signal that is upregulated by azacitidine exposure, and the combination of azacitidine and magrolimab synergizes to enhance phagocytosis. This is Dr. Sallman's work showing the phase 1 study of magrolimab with azacitidine and MDS. Again, I'll note a slightly different TP53 population, but still 1 of 4 patients on the trial had a P53 mutation. We saw the anemia data. I think thinking about this and relating this to the PD-L1 experience, it's different to have toxicities that happen but go away versus toxicities that persist and occur throughout the treatment. And I think the way that we frame or understand toxicities, is this something that I need to prepare for but will get past, or is this something where it's going to be an ongoing problem is important to consider? As we saw, the responses are high. Many people have a blast reduction. That said, the CR rate, again, was 32%. So 31 out of 95 patients responded, and we'll just remember that number for a little bit. Survival, very encouraging. I think an important thing that we should do more of in MDS trials, this study did permit ongoing follow-up post-transplant. Transplant's a core element of our treatment paradigm. If we're not allowing for post-transplant follow-up, we lose a lot of data. And that's shown here in kind of how important allotransplant was for the survival curves in this study. And when we think about when we're trying to give some patients total therapy, going from an initial therapy into either maintenance with our azacitidine model or transplant, we need to be able to see who benefits from transplant, who benefits from azacitidine, and when we might select patients for each. We saw the P53 mutational status data, and I think I would just highlight again how important randomization is for understanding the meaning of these kind of data. And so this is excellent data to give us a sense of what to expect for later phase studies. It's a challenge, though, for us to really interpret, again, even against historical controls, the heterogeneity of P53 remains really vexing. And so what lies ahead for magrolimab? Well, the overall response rate in the phase 1 study was numerically improved. We have a lot of these responses that are blast reduction with varying levels of hematologic improvement. I don't want to diminish. There are definitely patients who have benefit in those groups, but how do we better identify them? Maybe some of the changes that we've proposed for how response criteria are assessed can help with that. But for right now, we kind of have to use the old CR definition. Overall survival, again, there's challenges around predicting survival in a single-arm study. We again note that P53 mutant disease, the challenge of our time, the proportion of P53 mutated patients that get enrolled into any one of these studies, it's hard to know whether that's going to help us or hinder us. And this is a little bit of an aside, and maybe we'll hear more tomorrow, but it's also challenging in that many of the historically chemo-responsive patients, say you're low blast NPM1 or CBP alpha, we're now moving them into an AML classification. Is that going to further change our expected response rate if we've taken out more chemosensitive patients? And I've talked a little bit about using our old CR rate, and just to show that, we did a study where we looked at how many CRs would you actually need to feel confident about a 30% remission rate in a later phase study. And so for magrolimab, they had 31 out of 95 patients get CR. If you wanted to be confident that you'd be greater than 30%, you'd actually need 37 out of 95 responses. So it's really hard in phase 1 to predict later. So to conclude, antibody therapies and MDS, they have a unique activity. We need to design studies that will anticipate the impact of the treatment. And in particular, we need to account for molecular risk. Does TP53 mutation inclusion in your study help or hinder? And maybe we should just separate them into their own cohort, not to exclude them from studies, but power it separately. The magrolimab and sabatolimab phase 3 studies have enrolled. I'm excited to see what we learn from these studies. I hope that we get a number of new therapies in high-risk MDS, but at the least, I hope we can learn where antibody or immune therapies may have the biggest impact. So thank you very much.
Thank you, Dr. Brunner. Our next topic is targeting Dyserythropoiesis in clinical practice, and I invite to the podium to Eva Hellström-Lindberg.
So thank you very much. Thank you for inviting me to this fantastic meeting. We will now switch gears from more high-risk MDS to the role of anemia in MDS and how to sort of handle that for our patients. And I've been specifically asked to talk about this in the context of the clinical practice. No, I should perhaps, how should I do? Huh? Ah, it works there, but not there. Okay. Sorry.
It's not the same
Sorry,
as
can
that.
was that the... Okay, fine, so let's go then. Okay, so MDS, as you know, origins in the hematopoietic stem cell compartment, and we know that anemia is the most frequent anemia. This is then data from the Swedish complete cancer register of the MDS cohort, and at diagnosis, sorry, it doesn't look the same there as there. So at diagnosis, 49% of patients are transfusion dependent, and about 85% have anemia according to the WHO criteria. But neutropenia is only seen in 20% of the patients at diagnosis, and thrombocytopenia is also less problem at diagnosis. So this is a typical man, MDS with ring sideroblast, coming in for transfusions every 14 days for many years. These patients can live for 10 years or more if they are well managed with regard to iron content and their access and so forth. And the curve you see is one of all the curves showing that if you are transfusion dependent at diagnosis, this is old data from a prospective publication in New England from Mori Cazzola many years ago, but all the curves look the same. So being transfusion dependent at diagnosis will actually make you live for a shorter time. We don't know the reason for this. We don't know if it's the effect of anemia. You stumble more, you fall more, you get more heart failure, whatever. We don't know if it's the effect of iron overload. That may actually impact survival later on, perhaps not from the first day. Or we don't know if it may reflect a worse MDS biology. Probably all of these three reasons are intermingled in the explanations. So Dyserythropoiesis and MDS are of two kinds, and of course sometimes they are mixed. The first is erythroid hypoproliferation, reduced frequency of erythroid bone marrow cells when you look in the smears, and they usually have fairly high serum EPO levels, not always allowing for EPO treatment. 5q- syndrome is typical for this type of MDS, but also hypoplastic MDS when the bone marrow may be targeted by the immune system. Most high-risk MDS have a reduced erythroid compartment in the bone marrow, and in particular, and I think you recognize this, MDS-MPN unclassified and MDS with severe fibrosis. These are patients in which the erythropoiesis have sort of disappeared. The other type of MDS is the ineffective hyperproliferative erythropoiesis with an increased frequency of erythroid bone marrow cells, usually normally or slightly elevated EPO, making EPO treatment a very good choice. The classical model is MDS with ring sideroblast with SF3B1 mutation, but also many other low-risk MDS with splice factor mutations and some other lower-risk MDS. I just show you the slide here. You see a bone marrow slide from an MDS-RS patient. Being around 60, you are supposed to have 40% cellularity, 20% erythropoiesis if you are healthy. If you are an MDS-RS patient, you may have an 80% cellularity, 50% of all cells being erythroid cells, and 50% being ring sideroblast. You have an enormously expanded erythropoiesis, basically if it's in the worst case scenario, not giving out any red cells at all. Pedro Moura will talk about that tomorrow at the final session. So what are then the clinical aspects of treating the anemia of MDS? The indication for treatment, I think we agree on that now, both from the NCCN and the European perspective, is symptomatic anemia. Doesn't matter if you're transfusion dependent or not, and I will come back to that. Individual assessment. Some patients cannot walk with a hemoglobin below 100, and some can work 100% of time with a hemoglobin of 70. So it has to be targeted back to the individual patient. Always, of course, in the case of transfusion-dependent anemia. For the 5q- syndrome with a hyperproliferative erythropoiesis, EPO is first-line treatment. It usually works quite well if you don't start too late. Perhaps it has a shorter duration of response than we see in some other types of low-risk MDS. And then we have lenalidomide as second-line treatment. For the hypoplastic MDS, we can use immunosuppression. The old ATG cyclosporin A studies works sometimes very well in combination with erythropoietin. Takes a long time for these patients to respond. You may have to continue for a year, but it's very often a successful treatment. Most higher-risk MDS do not respond to erythropoietin, and they need something else. And usually today in clinical practice, azacitidine, if you think that is the optimal choice. And in particular, MDS, MPNU, and MDS with fibrosis, they don't respond always so well to azacitidine, but today we don't have any other documented treatment. If we have the ineffective hyperproliferative erythropoiesis, it's basically EPO unless you have an SF3B1 mutation when luspatercept is actually approved both in Europe and in the US. I come back to the availability of these treatments. So for other lower risk MDS treatments, it's just EPO that we have. But for all types of MDS, when we have to give up pharmacological treatment, we have targeted transfusion therapy and chelation, and I have a few words about this in the end. So we have heard about the del(5q) MDS. I will only show a couple of slides. So lenalidomide is second-line treatment for del(5q) MDS. These are data from the pivotal 004 study, and this shows then the duration. No, this is then the AML-free survival, sorry. And you can see that the red curve is the responders, and they have an AML-free survival of 4 years. It may be good if you are 75, but if you have del(5q) and are 40 or 50, which is not uncommonly the case, this is not a perfect outcome. And if you are a non-responder, then for me, this is a patient that I should take to transplant. So the transfusion independence in this study was about 50%, 60%, with a median response duration of around 2 years. And responding patients showed marked reduction of del(5q), but not of del(5q) HSC, as shown by for example, Sten-Erik Jakobsen's group. So lenalidomide acts cytotoxically against the del(5q) containing cells, unless they are HSCs. And we know also, I'll be short on this, that the presence of p53 mutated cells actually is very dangerous when you give these patients lenalidomide. They have a very high incidence of transforming to AML. The transformations could be extremely rapid, very often p53 mutated. You can't really do very much when you're in this situation. There is a very elegant recent paper in Blood from Sperling and co-authors showing then mechanistically why this is the case. So read this paper. Lenalidomide has the ability to both promote the actually occurrence of TP53 mutated cells and, of course, also selecting them during treatment. So that's why the study that I will not show, because this data is under embargo until EHA, a couple of months from now, a month from now, is a retrospective study of lenalidomide discontinuation in patients with myelodysplastic syndrome with del(5q). And this will then be presented at the EHA by Elena Krisa. And I think this is actually a way to go. If you want to induce the effect of lenalidomide, perhaps you don't have to continue to press len on these patients. So back to erythropoietin then, and I will go through a couple of European studies. This is then the large EU MDS register, where we looked and published in 2017 the effect of presence of ESA treatment for these patients. Patients could be treated in any way. It's not interventional trial, and the availability to actually give patients ESA were quite different over Europe. And what this study shows is that if you start ESA treatment before the onset of a permanent transfusion need, this actually is associated with a significantly longer time to your first transfusion. The same has been shown by Rena Buxton and her colleagues in the Canadian register. And recently, this is just preliminary data reported last year at EHA. When we repeat the study and the analysis now, 6 years later, we show that being exposed to ESAs, if you have a low-risk MDS, is actually associated with an improved survival. So I think it's very good, very important for patients to prevent onset of transfusion need. Okay, so this has now been further taken on by Maria Creno at Karolinska in our research environment. And Maria talked about these data. I will just repeat 2 of these slides. These are all the patients from the IPSS cohort. The blue ones are those at diagnosis being transfusion-free, and the yellow ones are actually those being transfusion-dependent at diagnosis. And as you can see from this Sankey diagram, each bar is then 4 months, is that the majority of changes in transfusion state for these patients occur within the first year, and actually the vast majority occur within the first 4 to 8 months. The improvement and people being transfusion dependent and being transfusion independent for the rest of the course of their disease have actually either been given erythropoietin, majority, or azacitidine, a slightly lower part. And what Maria has then presented and showed is that if you look at the first, the left slide of these are the blue ones are lower risk MDS, IPSSM cut off by in the middle, and the purple ones are higher risk MDS. And in lower risk MDS, the same curve as I showed you, being transfusion dependent at start is actually associated with a worse survival. But I would like you to focus on the third curve, the 8 months landmark analysis. So this is then curves drawn from landmark 8 and divided whether you have reached transfusion independency or not. And as you can see, lower risk MDS patients who have failed to reach transfusion independency fare approximately as well as higher risk MDS patients who have succeeded to reach transfusion independency. And interestingly, this holds both for TP53 mutated cases, higher risk, and for the SF3B1 mutated MDS-RS. So I think that time-dependent transfusion need will be very important. So SF3B1 is an early initiating driver mutation in MDS with ring sideroblast. This is a study published by Teresa Montera Blanco from our group some years ago. And SF3B1 is the driver mutation in the progenitor colonies and also in the LTCICs. We find in these patients single clones that are unmutated. These are the white ones here. And then this was taken forward in another publication by postdoc Isabel Hoffman. And I would like to look at these groups. The blue ones are patients who are not in the need of treatment, not in the need of EPO, not in the need of transfusion. They pedal on maintaining an acceptable hemoglobin level by themselves. The red ones are patients not responding to EPO, and the green ones are actually those responding to EPO. So what we show here is that the variant allele frequency in the stem and progenitor cells in patients maintaining the hemoglobin by themselves actually are significantly lower for both the very early stem cells, the HSCs, the MPPs, and so forth, and in the progenitor compartment. So being HSPC low VAF for SF3B1 is actually associated by keeping up a good hemoglobin level. This has not really been assessed in any other types of MDS. Okay, so now luspatercept, you know that this is super beta, TGF beta super family ligand trap, and I will then go directly and summarize these data. So it's licensed in both EMA and by EMA and FDA for MDS with ring sideroblasts in transfusion-dependent anemia. In the US, I think you use it when you have the insurance covering it. Fortunately, in Europe, it's not available in the majority of countries. In some, yes, but not at all. For example, we can't give it in Sweden. It's also in spite of a fairly healthy healthcare budget. There was first a PACE study, including long-term follow-up, showing efficacy in all sorts of low-risk MDS, better in the MDS with ring sideroblast, safe long-term data and effects. And then there is the medalist study that has given rise to a number of secondary publications. In the primary study, the transfusion independency within 24 weeks was 38%. There were 28% of patients responding for more than 12 weeks. If you have a low transfusion burden, you have a much better response rate than if you have a high transfusion burden. You get a bit more response with long-term treatment. The VAF, they say, doesn't impact the response rate. However, they looked at the VAF in the mononuclear cells, which is not really sufficient. But there is no reduction of the frequency of mutated cells in responding patients. Okay, so conclusions then and prospects. For erythroid hypoproliferation, we have drugs. We have EPO, when the serum EPO is not too high, lenalidomide. We have immunosuppression therapies. Len inhibits the clone, but there is no evidence of a true stem cell effect of this clone. When we have ineffective hyperproliferation, we have EPO, we have sometimes luspatercept if you are lucky. There are many drugs in trial, but so far nothing that really hits the ceiling. Effective treatment acts equally on mutated and wild-type bone marrow cells. However, early treatment gives better and more durable results. I think that is a lesson to learn. Investigations, I think, for the future needs to focus on mechanisms for efficacy. It makes me sad that we have such elegant preclinical studies bringing us the new drugs, and when the new drugs are brought into phase 1-2 trials, no one really cares about which cells they infect, whether they infect the clone or with the immune system or the microenvironment, whatever. We have to be better in understanding what we do. And then finally, we need high-quality transfusion therapy with individualized HB target levels and focus on optimal quality of life and physical function. And with that, thank you very much.
Mm-hmm. Thank you. So we invite now the last speaker, so Daniel Novak, for the presentation about 5-azacitidine in combination with a novel pan-lysine oxidase inhibitor synergistically restore erythropoiesis in myelodysplastic malignancies. Thanks.
Thank you very much for the introduction and choosing our abstract for oral presentation at this very nice congress. I'd first like to thank my two postdocs, Xingyu and Vladimir, who put a lot of hard work into this project. So what this here showed my disclosures. There is some funding from the company who developed the substance I'll be talking about. So the background for this project is that so-called LOX enzymes, lysyl oxidases, are overexpressed in stromal cells that are derived from MDS patients as compared to healthy people. We discovered this several years ago by RNA sequencing of these cells as one of the candidate genes. And this may be an interesting approach for therapy because these LOX enzymes in the bone marrow microenvironment are responsible for the cross-linking of collagen fibers, and therefore the hypothesis is that these contribute to reconstruction or remodeling of the extracellular matrix in the bone marrow microenvironment in form of making fibrosis and changing the whole architecture. And we validated this concept, so the higher translation of the higher gene expression also translates into increased concentration of these enzymes in the bone marrow microfluid. and also in higher activity of these enzymes. We tested this in over 100 patients, mainly from MDS, but also from AML and CMML, so myeloid neoplasia. That's what the abbreviation MN means. So you can see here it's really overexpressed, and also the activity is increased. And fortunately, this aberrant LOX activity can be inhibited by LOX inhibitors. So we were working with this orally available LOX inhibitor from an Australian company called Pharmaxis. This is currently already in early phase clinical evaluation, for example, for primary myelofibrosis, and up till now has a very favorable toxicity profile. Actually, there are hardly any toxicity signals from this substance. And the aim of our study was to preclinically assess the effects of this substance as a single substance, but also in combination with an established therapy. So we chose 5-ASA as a backbone for combination in some preclinical MDS models. So because LOX enzymes are almost exclusively expressed by MSCs, but not by hematopoietic cells, we chose different preclinical models, which also include interaction of hematopoiesis with the bone marrow microenvironment. So for an ex vivo setting, we chose this co-culture assay, where we put HSCs on top of a layer of bone marrow-derived MSCs. Here the cells are in contact. And in this setting, we can actually pre-treat the stroma layer for several days, for example, with PXS. Then do a co-incubation of 4 days, and then subject these HSCs to colony-forming assays to assess their differentiation. In the second line of preclinical models, we use the xenograft model, which we established some years ago, and which we have now several times successfully used. So I'm actually proud to say this was awarded twice with the Tito Bastianello Award in this meeting. And this model consists also of co-transplantation of MSCs and HSCs into immunodeficient mice. And this offers the unique opportunity to multiply one patient sample into several mice to test different treatment conditions. So the conditions we tested here were control, 5-ASA, so the mono substances, but also the combination of these two. And lastly, we are currently, I'll show you some preliminary data also of the substance combination in the well-known HOXD13 transgene MDS mouse model. So we used roughly a little bit over 30 patients, majority MDS, CMML, but also some AML patients. Some of these patients were already pre-treated, so they are not only initial diagnosis. They've partly been heavily pre-treated with all different risk groups. And yeah, this is the result from the in vitro assay, and we were actually quite surprised. So the readout were colonies after this setup of pre-treatment of the stroma layer of 7 days plus co-cultivation of 4 days. Because in comparison to control, the single substances didn't actually exert a great difference. However, the combination really showed a lot more colonies, especially erythroid colonies, and this was partly also visible by bare eye if you centrifuge those samples down. And yeah, because I don't like colony counting a lot, we also developed a FACS assay to test this differentiation. And here you can see the same results. So control and single substances didn't really lead to an erythroid differentiation. So this is erythroid, late-stage erythroid differentiation as measured by glycophorin A. But with the combination, we were really able to differentiate these cells into late-stage erythropoiesis. And here in this table, these are the results for the 31 patients. And you can actually see that the redder this gets, the more differentiated the cells get into erythropoiesis. And of course, as compared to control, some cells from patients react to 5-ASA alone. The single substance LOX inhibitor doesn't actually do much. But if you look at the combination, you get this group here on the right on top, which is over 30%. which is basically an erythroid response in this setup on top of the normal response you would expect from 5-ASA. And this, yeah, this really surprised us. So we went further and asked the question, is this dependent on the interaction with the stroma? And this slide answers this question, yes. So this is very clear. This effect, which is induced by this substance combination, only works when the HSCs are put in direct contact with the MSCs. If you treat the HSCs alone with the substance combination, actually nothing happens. So yeah, this is with different intensity. So there's some samples that work really well and others that only work partially. But it's very clear that you need contact to the MSCs to have this effect. And we also looked at the stromal layer. So what actually happens if you culture those MSCs in a 6-well dish, for example, they really build a robust extracellular matrix layer, which you can then decellularize. And on this slide, we asked the question, do we need the cells, or is it enough if the HSCs are in contact with the decellularized ECM? And the answer is so-so. So the HSCs alone, of course, you don't have the effect. If you co-incubate the HSCs with a decellularized ECM layer, it partially has this effect, and you have the full effect if you have both cells plus the decellularized ECM. We also confirmed these results in a xenograft model because, as you know, in real-life clinic, patients often only respond to 5-ASA treatment after several months. So this mouse model allows to simulate this situation in a better way. So here we had a 3 months experimental setup, including 3 normal cycles of 5-ASA, so the classical cycle as you would also do it in the clinic. And the mice were constantly also co-treated with PXS. This is orally available. So here the results were confirmed. You also have this synergistic boosting of erythropoiesis in the mouse model. But we also saw that other important clinical parameters were influenced positively. So there was also a reduction of spleen size, or the spleen remained at a normal size while control or the single substance had spleen enlargements in these mice. There's some indicator that this may also reduce disease activity, as shown by engraftment rates in these mice. So here engraftment rate in the combination was able to lower the engraftment rate the most effectively. And interestingly, so I'll just go back once more. So we also exome sequenced these mouse experiments every 6 weeks. And from this we were able to assess the molecular course throughout this time. So here the combination was most effective in reducing the dominant clones. If you look at these red lines, this goes down in the best, most effective manner as compared to the single substances or control. So this is the last result slide. We're just testing this also in the HOXD13 model because, as you may understand, a PDX model of primary samples is not very useful to really study mechanisms. Therefore, a standardized transgene mouse model is better. So we're just optimizing the conditions for this. You can see, here after 1 cycle, actually HB goes down in blood. This is because 5-ASA is quite toxic in these mice. In our following experiments, we have reduced the doses. But nevertheless, there seems to be a trend that it may also work in this model. That would be good because then we can use this model to study mechanisms. So I'll summarize. I think these data show clearly that this new substance combination of the LOX inhibitor and 5-ASA really boosts erythropoiesis in MDS and also other myeloid neoplasias. This is remarkable because a lot of these samples have been heavily pre-treated, so they've already seen 5-ASA or even 5-ASA and venetoclax. It reduces disease burden in the mouse model, and this is really a genuine niche-targeted treatment because we're not, at least with the LOX inhibitor, we're not treating the HSCs, but we're directly treating the bone marrow stroma. And as an outlook, of course, we further want to analyze this mechanism. Why does it work so synergistically? Does it work with decitabine? And of course, it would be good to combine an oral substance with oral 5-ASA. This would be very comfortable for the patients. And of course, we want to translate this into the clinic, and we are currently preparing an IIT at our institution, which I hope we can start soon. So lastly, I want to thank my group and all our collaborators and funding. Thank you very much.
Yeah, so we are sorry we are really late, but if you want, we can take maybe a short Q&A session. So if all the speakers want to join us, maybe one or two questions. So maybe one question for me. Maybe for all of you. Do you think we have to continue a clinical trial for MDS and EML for TP53, or if now we have to combine and do only clinical trial in TP53 mutated MDS EML to accelerate the development? Maybe David.
Yeah, no, I mean, I would argue that we should definitely combine the cohorts. I think really, all patients with more than 5% blasts, we should combine it. And I truly feel, even across in earlier studies, we need to separate these patients out. I think it's also blunting some of the development in wild-type patients at the same time.
Thomas, yes, here. Michaela Fontenay. So it's a question for Daniel. So thank you all of you for the great presentation and great talks. I would like to know, Daniel, you have studied a large spectrum of samples, low-risk MDS, high-risk MDS, and CMML2. Did you observe any differences in the recovery of erythropoiesis or between the samples, or maybe the effect was exactly the same?
So unfortunately, we didn't discover any pattern. Otherwise, I would have presented it, of course. So we were looking very hard for that, looking for biomarkers for response. So far, we haven't found anything yet. No, it's not dependent on risk stratification or molecular parameters.
So I would like to follow up on that question. So when you do your PDX models, I suppose you may have both wild type and mutated cells. Do you check at your follow-up time points? Do you check by digital PCR the relation between mutated and non-mutated?
Yes, we serially sequence all of the samples. So we sequence the input sample, and then we do bone marrow aspirations every 6 weeks, and of course also at endpoint. So we can quite well follow the WAFs, how they change upon treatment.
And did you see that hemoglobin increase was associated with an increased wild type fraction?
Yeah, so here our results are a little bit different between the in vitro assay and the in vivo. So in vitro, we really see that the erythropoietic cells that differentiate are almost void of the dominating mutations. So in vitro, it looks like there's healthy cells or cells that are less mutated that contribute to the erythropoiesis. Unfortunately, we couldn't clearly so far confirm that in the in vivo setting.
In
so
the PDX.
yeah, yes.
If there are no more questions, we close this afternoon session, and we invite you to a break and later on to the last session today that is, I think, very relevant and is a focus on outcome research.
Thank you very much.